This is Elizabeth Claydon. I'm going to be talking to you today about eating disorders. I'm an assistant professor at WU, and I also work with the Injury Control Research Center. So as an overview today, we're going to be looking at what eating disorders are, sort of the different types of eating disorders that are involved, how we can treat them, some novel as well as some traditional treatment approaches, what are some steps for prevention, and then some special populations, including eating disorders and pregnancy, and then areas for future research. The learning objectives for today are to name and describe the main types of eating disorders, to understand conventional and novel ways to treat eating disorders, and to list some steps for prevention, and then discuss the unique challenges facing pregnant and postpartum women affected by eating disorders. So what are eating disorders? There are a few different main types of eating disorders, including anorexia. Anorexia is defined primarily as the fear of gaining weight and a weight below the 85th percentile. There was also an inclusion of amenorrhea a few years ago, but that has been dropped to make sure that we include the diagnostic criteria to be more applicable for men as well. Bulimia is another one of the main types of eating disorders, and that is defined as periods of binge eating as well as compensatory behavior afterwards, such as either vomiting, using diuretics or laxatives, or even overexercising. Binge eating disorder is another one of the main types of eating disorders, and it is a newer diagnosis in the DSM-5. And that includes binge eating, so eating large amounts of food in a short period of time, but no compensatory behavior afterwards. So there's no vomiting, there's no overexercising, there are just these large quantities of food eaten and a loss of control. Then there are other specified feeding and eating disorders, OSFED, which was previously known as eating disorders not otherwise specified, or EDNOS, which was in DSM-4, but OSFED is now known as in DSM-5. And then also avoidant restrictive food intake disorder, or ARFID, which we often see in younger children, but we can see in adults as well. And ARFID really deals with sort of this restrictive food intake. They might be very reluctant to eat different types of food, different textures of food, and this often comes after maybe a traumatic incident, such as choking, or sometimes children with some sensitivity issues may be very reluctant to eat different types of food. So the statistics are pretty alarming for eating disorders. They have the highest mortality rate of any psychiatric disorder, and this is especially true for anorexia, which has the highest mortality rate among eating disorders in general. And anorexia, those who die from anorexia die primarily from heart attacks, or they die by suicide. The prevalence for eating disorders is relatively low in the population, but those who suffer from disordered eating is much higher. But the overall prevalence is 0 to 5% depending on eating disorder type. Anorexia and bulimia tend to be a little lower. Binge eating disorder tends to be a little higher, but we don't have quite accurate prevalence rates on binge eating disorder yet, since it is a newer diagnosis. We also know that hospitalizations for eating disorders have increased 18% from 1999 to 2006, with those for children under 12 increasing by 119%. So this is becoming a much bigger issue, especially in younger ages as well. And then federal spending is not really catching up to the problem of eating disorders and to the treatment needed for eating disorders. So it's 20 to 30 million that is spent annually on eating disorders, or about 93 cents for every person diagnosed with an eating disorder. As a comparison, diseases like autism are allocated about $44 per person diagnosed. We also see that the statistics among sexual minorities are much higher. So 3.5% of sexual minority women and 2.5% of men have an eating disorder, as well as 16% of transgender college students. So in these populations, it's a much higher concern as well. So there are a few different types of treatment for eating disorders. These are some of the more tried and true treatments or conventional treatments. Cognitive behavioral therapy is really the cornerstone for a lot of mental health treatment, and that is true for eating disorders as well. So CBT is used for adults with bulimia, anorexia, and binge eating disorder, and it's been used fairly successfully. Family-based treatment, or FBT, is recommended for adolescent patients with anorexia, and that's really used to make sure that the family is involved in the process and can help the adolescent patient the entire way through their recovery. Enhanced CBT has been effective for treating OSFED, so those other specified feeding and eating disorders, which are those that just really don't quite fit into the other diagnostic criteria for like bulimia, anorexia, or binge eating disorder. And then there are behavioral strategies to reintroduce foods for ARFID. So for example, trying to help someone learn how to re-swallow, reintroducing textures to those who have been uncomfortable trying different textures of food. And a lot of that's, with different occupational therapists and speech therapists who help with swallowing techniques. And then fluoxetine or Prozac has been approved by the FDA for bulimia treatment and can also be used for binge eating disorder treatment as well, especially in combination with cognitive behavioral therapy. And that's really used to try to decrease some of the binge eating episodes and can also improve mood. Novel treatment, there are new medication-based treatments being used for binge eating disorder, such as the medications Vyvanse, Topremate, and Orlistat. And those really deal with appetite suppression and also trying to decrease some of those binge eating episodes. And so they deal a lot with the behavior. They may not necessarily address the root cause of binge eating disorder, but they can at least address the behavior so that then methods combining CBT and weight loss interventions can be used with those medications, and that's where the most promising results have occurred. So when we look at prevention, really we think that primary prevention is probably the best for both preventing eating disorders and preventing obesity or preventing eating disorders across the spectrum, so from anorexia to binge eating disorder. So looking at intergenerational transmission, there's both a genetic component and an environmental component to eating disorders. Some of my research has involved intergenerational transmission, looking more specifically at eating disorders and dieting behavior from an environmental perspective, especially in the social environment at home. There's some research to show that parental comments are significantly related to daughters' adult BMI and weight dissatisfaction. There's also some studies that show that girls and mothers who are currently dieting were more likely to diet prior to age 11. And perceived maternal weight-related comments are associated with adolescent weight concerns. And this just is an obesity and dieting proneness theoretical model that I generated to show, and based on an original model by Costanzo and Woody, that just sort of shows how children sort of internalize concern about their weight and become unable to self-regulate their eating or engage in dieting or other disordered eating behavior from parental perception about a child's weight, parental values about weight, and parental concern about their own weight, and then parental concern about a child's weight. And this just sort of feeds into a loop that when parents comment on a child's weight, or parents might engage in fat talk or modeling dieting. So this can be just an unhealthy environment that is created for the children at home. And if there's a genetic predisposition already for an eating disorder, this can just exacerbate that problem. And so when we think about this from a prevention standpoint, just trying to make sure that children from a very young age are encouraged to have a healthy relationship with their bodies and with food, that's really the best thing that we can do. So I'm also looking at a special population in terms of pregnancy and eating disorders, and that's where some of my research is going now. And this is an area that's not explored a lot, so I want to touch on this today too. So women with eating disorders are more likely to react negatively to pregnancy. We know that the reactions improve at around 18 weeks gestation. We're not quite sure exactly why that is, but that might be because that's when they find out the sex of the child. They might also, have more of that baby bump and be able to sort of realize more, okay, this is actually happening, and be able to see the effects of the pregnancy more, rather than just see the weight gain going up on the scale. There's also a higher rate of unplanned pregnancy in this population. So there's a 2-fold increased chance with anorexia, and then a 30-fold increased chance with bulimia of unplanned pregnancy. And this, to some extent, is because of interrupted menses with anorexia and sometimes with bulimia. So with anorexia, you can get amenorrhea, where you have the period stop completely, or oligomenorrhea, where there's interrupted periods. So then the individual believes that maybe they cannot get pregnant. And then additionally with bulimia, there are some correlations with risky behavior taking. So they might also participate in riskier sexual behavior. So because of these two factors, the unplanned pregnancy and the negative reactions to pregnancy, pregnancy and motherhood can be extremely traumatic for this population. So it's very important to understand in order to improve outcomes, bonding, and decrease the likelihood of intergenerational transmission. And then we can also really improve maternal and fetal and child outcomes for this population if we intervene during pregnancy. So there are a few qualitative studies that have looked at pregnancy and eating disorders that have found that pregnancy experiences protect against body dissatisfaction. So things like feeling the baby kick, seeing more of that baby bump, hearing, the baby's heartbeat on a monitor. Those kind of things help protect against body dissatisfaction. But those protective factors disappear postpartum, which we know is a challenging time for mothers anyway. And then there's another study, Tierney et al., 2011, that identified 3 types of women with eating disorders during pregnancy. So there were women who were quote-unquote cured of eating disorders through motherhood, and then those who temporarily recovered during their pregnancy for the sake of their child, but went back to eating disorder behaviors after pregnancy. And then there are some that continued eating disorder behaviors throughout their pregnancy and couldn't put those on hold. So identifying eating disorders during pregnancy is very challenging. If it's not in their history, many women will choose not to disclose because there is some amount of stigma included with this. And there can be quite quick questionnaires to use to screen for eating disorder pathology and disordered eating, such as the SCOFF, the Eating Disorder Examination Questionnaire short form, which has about 28 questions, and then there's the Eating Pathology Severity Index, which has 45 questions. If they score high, it's recommended that they be referred to both a nutritionist or a dietitian, and then therapists, and if needed, a psychiatrist experienced with treating eating disorders. However, the caveat to those questionnaires is that they aren't always valid during pregnancy or postpartum. And I'll give you just a look at the SCOFF, which is the best one to use for a quick clinical screening at this point because it's so short. It's, really just these 5 questions. So do you make yourself sick because you feel uncomfortably full? Do you worry you've lost control over how much you eat? Have you recently lost more than 1 stone or 14 pounds in a 3-month period? Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? So if you look at some of these and think about them from a pregnancy standpoint, some of them are a little challenging and may not be valid in that population. So, for example, just highlighting one of them, have you recently lost more than 1 stone in a 3-month period of time? Well, that's not necessarily going to be valid for a pregnant population or even for a postpartum population. It would come up with either a false positive or a false negative. And then when you say that food dominates your life, that can be challenging for a pregnant population too, because of the pregnancy cravings. It may be a little bit dominating during pregnancy, and that may be somewhat normal. So the scoff is very rapid, but it may not be the most accurate. So one of the things I did recently was a qualitative research study looking at pregnancy and eating disorders, and interviewed 15 women who had either been pregnant or wanted to become pregnant, or didn't want to become pregnant related to their eating disorder. And so there were a few different themes that we found from these interviews. There was this issue of control and sort of lack of control, both of their eating disorder and of the pregnancy, weight and body image concerns, which is understandable, this battle between pregnancy and eating disorder in terms of their decision whether to have a child, emotions towards pregnancy, which we talked about, the negative emotions towards pregnancy especially, the focus on the child and ability to be able to put their eating disorder on hold during pregnancy or not, coping strategies and how they got through the pregnancy, also whether they disclosed to others about the pregnancy, including physicians or loved ones, and that intergenerational transmission piece as well. And I wanted to highlight some of the representative quotes just about disclosure to others when thinking about especially disclosure to medical professionals. So one of these quotes is from Melissa, 28. She had a previous aborted pregnancy and has not had a child since. And so she said, "I kind of just latched onto an eating disorder. It was my best friend, my little secret. It was just mine." So she didn't really tell anyone about this too much. And if you think about, if she has a child in the future, would she be likely to tell a provider if they didn't ask? And how do you go about asking someone who's struggling with an eating disorder about their eating disorder if it's such a secret? And then Amelia, 27, mother of one, said, "I have never sought treatment. It's sort of one of those things, like they can take everything else away from me, but they can never take this away." So throughout her pregnancy, and she was able to put her eating disorder on hold during her pregnancy, she never told her providers about her eating disorder. She figured that if she could put her eating disorder behaviors on hold during the pregnancy, she didn't need to tell them, and she went straight back to her eating disorder behaviors after the pregnancy. But she put on hold for the sake of the child, and then went right back. And then Ruby, 31, a mother of one, did tell her providers, but just was speaking a little bit about the fact that even if you tell someone about it, they can't quite understand because they're not in your shoes. So my husband has no conception of it. He knows a little bit about that I had an eating disorder, but he really doesn't understand the mental processes that go behind it and the constantly being, I'm going to say, obsessed. And so this is to say, too, that, even if we try and ask people about it, it's very hard to understand from their lived experiences what they're actually going through. And that's a challenge as a provider when you're trying to give people the best care and understand their experience in order to help them as best you can. So in terms of thinking about some of these things for future research, there are interventions that are needed to prevent intergenerational transmission of eating disorders, thinking about that model and how parental comments can feed into children's concerns about weight, internalization about weight, and then dieting or disordered eating, or even just weight concerns in general. And the need to make sure that they're building a healthy relationship with their body and with food at a young age. There's also need for a valid rapid assessment tool for pregnancy and postpartum eating disorders. And there's a need for a referral guide to provide healthcare providers with a clear referral pathway. So it's very difficult to provide a valid rapid assessment tool for providers, and then they have a woman who screens positive. Well, what do they do then? So there needs to be a referral guide that they can quickly look at to know, okay, well, here's exactly where I should refer this patient, because you don't want to give them a tool without giving them a clear pathway. Thank you very much for your time today. If you have any questions, you can contact me. I'm always happy to reach out and answer any questions. And here are some references too. Thank you very much for your time today, and I hope you learned a little bit more about eating disorders today, and prevention and treatment, and a little bit more about pregnancy and eating disorders as well. Thank you again.